Now I'd like to introduce you to our final speaker, Dr. Genevieve Cabanato, an emergency physician and educator in ultrasound courses and workshops targeting emergency doctors at Royal Prince Alfred Hospital. Dr. Cabanato will discuss her experience in reprocessing ultrasound probes using high-level disinfection, HLD, in emergency departments. I'd now like to hand the presentation over to Dr. Genevieve Cabanato.
Hi, my name's Genevieve. I'm one of the emergency physicians at Royal Prince Alfred Hospital, and I have a real interest in ultrasound. I run a few workshops there, and one of my greatest interests has actually been on how we actually keep the probes clean so that we don't infect the whole department. Issues identified with current ultrasound practice within emergency departments. And how do we improve accredited staff on the floor? Emergency departments present very different challenges from other departments in the hospital, again, different from intensive care, and I'd like to discuss some of those challenges. In my view, accreditation is actually the cornerstone of safe practice, and there are some challenges with that, which I'd like to talk to discuss as well. Now, ultrasound is increasingly being used, as we've already heard from Dr. Costello, in intensive care, but also in the emergency departments. And we're not just using ultrasound for peripheral lines or for central lines or for nerve blocks. We're actually using it as an important diagnostic tool in patients with undifferentiated abdominal pain, chest pain, patients who present with shortness of breath, for example. So we've got this huge undifferentiated population in the emergency department, and we're using ultrasound on a lot of those patients. Now, we say that ultrasound is actually easy to use, portable, and considered to be safe, and it certainly is easy to use, which is why we're using it so much, but certainly, in my opinion, it is a very important vector for infection, and that's something that we have to address. This is a US observational study which surveyed ultrasound use and reprocessing amidst infection preventionists in healthcare facilities. And it shows that there is a lot of confusion surrounding high-level disinfection and sterilisation of ultrasound transducers, both before and after use in the clinical setting. And this is exactly what is happening in Australia. So everyone's got their way of doing things, and there's nothing that is really standardised. Now, I remember actually ringing ASIN just before COVID saying, can we please have guidelines? We need guidelines. We've got this COVID thing happening, and I want to know how we can protect our patients better because there really weren't any guidelines before that. There are some problems directly related to the emergency department, and in my view, they are related to the way people are taught. So ultrasound in the emergency department is taught in an ED training, late training. So they have all this lead time where they're using the machine and they haven't had any formal training, and that's a problem. Other thing is that ultrasound is actually used for procedures, and often the use of ultrasound with procedures is actually taught elsewhere as well. So in anaesthetics, on the wards, in intensive care, and the way in which it's being used, the way it's reprocessed depends on how it was taught in the first place. And then, of course, these people come back to the emergency department and then they just teach others exactly the same thing. So we have a variety of ways in which people are disinfecting or reprocessing their probes. Now, our trainees only stay in our department 6 to 12 months, and they may have done an ultrasound term elsewhere. And when they have done these ultrasound terms, they come back to us, and we assume that they know how to reprocess their probes. But everyone has different standards. So, there isn't one standard which, we're coming back to. We should all be doing the same thing. We have another problem, and that is that not all JMOs working in the emergency department are actually ED trainees. And so we have half our team at the moment. We've got 73 JMOs working with us at the moment. 35 are ED trainees, the others are not, but they're still using the ultrasound machine. The ultrasound machine is still there, but no one can really, no one's really looking at how they're using it. I mean, the problem is that JMOs actually will take the machine, or not just all doctors will get the machine and they'll just take it to the patient and they'll use it, and no one will see what they do before they use it on a patient, how they use it on the patient, and what they do with the machine or the probes afterwards. So really, all this is happening independently with no direct observation from anybody else, and that's a problem. Now, before we didn't have an ultrasound workstation, and now we do have an ultrasound workstation, and that actually makes a big difference because people bring the machines back to the ultrasound station, and there we have a possibility of high-level disinfection, and so it is a trigger for these machines to be properly reprocessed. Now, what are some strategies we can use? Well, for me, accreditation is really important, and having accredited ultrasound courses or workshops, which I run, that include mandatory sessions on ultrasound reprocessing is really, in my view, paramount. And it should be the same thing. We should all be learning the same thing and doing the same thing. So maybe this is something that we should start doing now, and in the next few years we'll get to standardisation of care in that sense. Okay, as I said before, having a cleaning station has really changed things for us and has made everybody much more aware about how to reprocess their probes. We're in the process of getting this poster up on the wall, which you can see below, to explain when you use low-level disinfection, when you use high-level disinfection, and this is all because of the guidelines presented by ACPIC. Now, what we've done in the emergency department is that we've got a machine that we say is ready to go, and that machine has been so all the probes have gone through the high-level disinfection, and we've then identified those probes as being clean by actually putting a paper bag on them. So if we do get a trauma or we get something that is really an emergency, someone can just pick up that machine. We have 6 machines in the department. They can just pick that machine and then go to the patient, and they know that the patient will be safe. And then that machine is brought back to the station afterwards to get cleaned. Okay, so what are some other strategies? Well, the most important thing in my view is that you need someone who's passionate about ultrasound as a staff specialist in the department that you're working in, because that's going to change culture. We would love to employ a full-time sonographer. That is just not possible at the moment, but if there was going to be any money in this, I would definitely say that we need a full-time sonographer. The reason for that is that the whole credentialing process can be shared, and also sonographers will have a little bit more time to accompany doctors in during their scanning and to help them, remind them about what they should be doing before they scan, when they scan, and after they're scanning. And of course, it is important to be able to liaise with cardiology, general radiology, and also O&G. These people come down to our emergency department, they use our machines, and we need to be able to know that they are doing the right thing with respect to the machines as well. Now, we've talked a lot about training the registrars, the JMOs, but there has been a lag time as well with staff specialists and consultants, and everyone should be doing the same thing. I think in our department, most people are happy about the fact that they should be cleaning the probes after they use them, and I would say that, with all the effort that I have put into it, I think that we're doing it pretty much a lot of the time, but I wouldn't be saying 100% of the time by any means. But it's really what's happening before people are examining patients that is important, and I think that has to be addressed as well. So we want to know for sure that the probe is clean, and so people should be cleaning their probes beforehand. Of course, we've got the system where if they've gone through the high-level disinfection machine, then we can actually identify them by the paper bag, but if that's not the case, then they need to clean the machine. But anyway, the challenges are enormous. The workload, the workforce is fluid. Our patients, it's a chaotic environment, but yeah, we're getting there.